So hello everyone, this is Ben. I'm the CEO and founder of Astron, and thank you all so much for joining the webinar. Today we have the honor to have Dr. Carrington to talk about the Haglund deformity, how he will be able to perform MIS lead. Uh, but to start with, let me give you a short introduction about Astron. Uh, so Astron was really founded because of one issue, which is the open Achilles tendon repair, including acute Achilles tendon repair and the Haglund deformities. Um, we haven't seen, or Dr. Wang, our co-founder, haven't seen a lot of complications, and including ruptures, nerve injuries, and deep vein thrombosis, and a lot of complications while he's working on open Achilles tendon repair, and then seeing a lot of patients with pain and without having a great results. So he having seen if there's a better solutions to solve this issue or the problems. Therefore, we co-founded Astron together with Eileen to start navigating if there's a better solutions. Therefore, we'll design Tendon Grasper as a single-use sterilized disposable kit. Now it's all available in the market to really address this issue, and it can be integrated with suture anchor, suture tape, or ultrasound. um, there's a lot of variance and a lot of availability, uh, different ways that you can do it. And then just a short introduction about the devices. First, we have the grasper, and then we have the telescoping needle. The grasper is pretty intuitive, where there's a bottom on the top. Simply just press open, and then pull the trigger to lock, where I believe Dr. Carrington will be talking a little bit about that later. So basically press open and then pull the trigger to lock to retrieve the needles. And we have our telescoping needle, where it's a removable needle tip at the top. And we have the suture guard to use it uh, to suspend the spring and also using to shuttle the sutures. So when we drop it down and it will simply just pull the tip of the needle, we'll be able to shuttle the suture all the way to the other side. So we can use ultrasound, and then we have some surgeon not using ultrasound, but it will give you the accuracy of using ultrasound, which Dr. Carrington will be talking about a bit that later. And so we're using ultrasound to visualize the tendon and create a small step incision, which is simply just less than 1 centimeter or a centimeter, and then to use an ultrasound or without it to guide passing the needle. As you can see over here, needle is passing right through the center of the tendons, and then we're shutting the suture and then just drop it to the other side and using our grasper to hook the needle and to retrieve the suture and that finish the first passing. Usually we'll do 2 to 3 times, and then surgeon now, when the proximal is complete, they can decide if they want to um, do the end-to-end repair or just bring down to the calcaneus and use the anchor to dunk it into the calcaneus. And of course, we can lock the proximal and the distal side with our locking techniques, which, if you're interested, we'll be sharing the videos through YouTube, or welcome to join during the ACFAS to see a hands-on demo. And this is Dr. Abig's patients. After 13 weeks, the patient will reported no pain and hike 2 miles every day, and it can do 20 single hill rise just within 13 weeks. And then the incisions less than 1 centimeters. And then definitely we have publications that's on our website. So please feel free to join to take a look at the paper applications or the white papers. But basically, we can significantly reduce the complication rate and then increase the ALFS score. And a little bit about Astron. Astron's founded in 2021, and until now, all the products FDA cleared, and then we complete more than 100 cases and still expanding in the States as we are the founder from Taiwan. but this is just a short introduction about Astron. And during the webinar, please feel free to drop the questions in the Q&A sections or the comments. We'll be having Dr. Carrington respond to that later after the talk. And so this is just some of the housekeeping. Without further ado, Dr. Carrington, please take it away.
All right, I'm going to share the screen. Thanks for joining us tonight. Kind of talk about ways in which we're approaching a difficult pathology in a what I feel is a better approach. I've been treating Haglunds, my whole career. These patients walk into our clinics, and we've had good results and successes with it. But there's always things that I haven't liked. My outcomes have trended with the literature. We have about 85 to 90% satisfied patients, but it's the complications that linger on some of these patients or that cause poor surgical outcome. So let me see if this is going. I share this slide a lot with some of my presentations because it kind of, goes to the heart of as we're trying to improve patient outcomes. Not everyone's always going to be satisfied. But it always gives us pause to think, all right, what are things that we can do different to make these patients happier with these difficult pathology and different things that we're treating? I have the pleasure to practice with Dr. Abicht. And if you know Dr. Abicht, he's one of the most passionate people when it comes to minimally invasive approaches. And he's always kind of lightly barking in my ear on ways that I can do things smaller and smaller. And this is one of the things that we first started looking at when we were repairing Achilles ruptures and using the Astron device. We were having really good outcomes with our minimal approaches to our Achilles tendon ruptures. And I thought, hey, are there ways that we can incorporate this technology to different pathologies with the Achilles tendon? And the Haglunds was the first thing that came to my mind. If we look at this patient, this is a classic patient that will come in. You'll see it on your schedule. It will say heel pain or Achilles pain, and you think, all right, heel pain, perfect, plantar fasciitis. Or if it's Achilles pain, you think, oh, great, it's just going to be some, insertional or proximal Achilles tendonitis. It's going to do great with physical therapy. But then this is the clinical picture of the patient you see walk in with these large calcaneal prominences and pain with activity. And these are difficult things to treat. They don't respond well to conservative modalities. We try all we can to pad the area. We try therapy. We try anti-inflammatories. But there's a triad that we're trying to treat with these patients. It's usually pain from the prominence of the bone. It's pain from the retrocalcaneal bursa. And then there's also insertional tendinopathies that develop. As these become chronic conditions, the collagen weakens and begins to degenerate at the insertion at the tendon. You'll get calcific depositions. You'll get mucoid degeneration. And so it becomes this very difficult chronic pathology. And the symptoms they're not just the bony prominence. It is a soft tissue pathology that you have to treat as well. The calcifications make it difficult. There are several theories on why we get calcifications and deposition within the tendons. What we believe, we think on a microscopic level, is that calcification deposits as the course of healing gets interrupted, and it's a blood supply problem. And as the healing gets interrupted, it leads to these intertendinous crystal depositions. And these can weaken the tendon, but they also cause a chronic inflammatory process because as opposed to just soft tissue against the bursa, you now have calcific bony prominences pushing against both the subcutaneous bursa and the retrocalcaneal bursitis. So you can't treat the bone alone. It doesn't fix the problem. There's tendinous pathology that needs to be treated at the same time. MRI findings, these are classic things you'll see. You'll see both the inflammation of the retrocalcaneal bursa. You'll see bone marrow edema within the calcaneus because of the pressures of the pull of the Achilles tendon. Oftentimes, you'll see partial tearing within the distal tendon, and those are the ones that you're concerned about. And maybe if we can just treat the bony prominences, is the tendon going to respond appropriately? But if they have chronic tearing, there is concern for further weakening of the tendon at the insertion. And then the tendial Achilles bursitis subcutaneously you have to treat too. So what are the surgical approaches? Well, there's four main ones that we kind of look at in the literature, and these are four approaches that I've used throughout my career, both lateral, central, medial, and endoscopic. And a lot of times I would say, well, my selection on how I'm going to treat these things depends on both the pathology, on where it is, but also my comfort level. There's different approaches that not everyone's comfortable with, and so you're gonna pick the one that you're most comfortable with, but it may not be the best one based on the pathology. The lateral approach is pretty common. It's a longitudinal incision just lateral to the Achilles. It's great because it does give you direct access to this posterior superior calcaneus, where you can resect both the bursa and remove the bone. The advantage is you're not violating the tendons. You're not splitting the tendon in half. It's a familiar incision for us to do. And there tends to be less wound tension when you close laterally as opposed to centrally. The disadvantage is you can't get to the medial pathology. And sometimes in these patients, when you do a sunrise view on radiographs, you'll see that there's significant calcifications or bony prominence on that medial side. And the lateral exposure doesn't give you appropriate visualization to remove that pathology. The largest thing that we see with the lateral approach is risk to the sural nerve. And anyone that's had a patient with sural neuritis knows this is a very, very difficult thing to try and treat post-surgically, and sometimes it never goes away. And so they may have relief of pain from the prominence, maybe the Achilles feels better, but if they have sural nerve neuritis that lingers, that becomes more painful than the initial treating pathology. And so that's a difficult thing that you want to encounter or don't want to encounter in a patient that you treat surgically. The central tendon splitting approach was kind of my workhorse for many years. This was the main thing that I did. It gave great exposure, but you did violate the tendon, but you had direct access to that insertion of the calcaneus that allowed a double row suture fixation, which I used for many years because it gave us a very secure and robust repair. And it was also good because you could just look at the bursa, you could look at the bone on both sides and really feel like you got a proper debridement. The problem was it is a longer recovery. And there was a big risk of wound healing complications in my patients. These patients generally fit a certain mold. They're usually a little bit larger and they have difficulty remaining non-weight bearing. When they rest and they're non-weight bearing, they tend to put the pressure right on the posterior aspect of the heel as much as you tell them to float that heel. And then you deal with these wound healing complications that linger and linger, and it prevents quicker return to activities in these patients. What about the medial approach? Well, the medial approach is good as well because you're avoiding violation of the tendon, but you're also avoiding the sural nerve. And this is why people started looking at approaching these on a medial based approach to avoid the sural nerve irritation. It's a little more technically demanding, but you also have limited lateral visualization, and it's not as commonly used. I would only use a medial approach if I felt that most of the bony prominence was along the medial aspect and I could do a proper debridement over there. But generally not kind of a go-to for some of this pathology. The endoscopic approach is another one that I've used. It's a two-portal endoscopic calcaneoplasty. You can remove both the bursa and resect the bone at the same time under fluoroscopy. The advantage is it was very small incisions and patients tended to recover very quickly. I use these a lot in our diabetic patients because of the risk of wound healing complications, and we found that the two portals did very well. But it was limited in how much you could debride the calcifications on the debridement. And there's a steep learning curve for providers that aren't doing a lot of endoscopic approaches. It's an odd area to first go in there, and you basically have to resect until you can see where you are. There's a lot of fat in Kager's triangle, the bursa itself there. And so it became a technically demanding procedure that not everyone was comfortable with. And it's not ideal for significant insertional disease because you're not debriding the calcifications on the tendon appropriately. So, well, what does the literature show about the outcomes of what we're seeing with all these approaches? This was a recent study. It was a single center analysis, and they looked at 44 consecutive patients treated with central tendon splitting approach. What they found, interesting enough, is 50% of their patients had complications that failed to respond at final follow-up. That's a large cohort of your patients. If I had a 50% success rate on a procedure, I'm going to look, how do I do this procedure differently? 13% of the patients had sural nerve entrapment. 37% had incisional healing complications because of the hypertrophic scar that would develop, and that would also limit some of the range of motion post-surgically for these patients. 50% of them had derangement of the Achilles tendon and ectopic bone formation post-surgically, and there was a 45% formal revision surgery rate on these patients. And so really, if we look at these, and there are some of the similar outcomes we've seen in my clinics with patients that I've treated, I think there's a different approach that we could look at. This was another study that looked at the surgical approaches for insertional Achilles tendinopathy. It was a systematic review done out of the OFA group. They looked at 17 studies. There were 703 patients, 746 feet, looking at different approaches, both the central splitting and lateral approaches. They found, even in their study, they had wound complications up to 3%, post-op rupture rates of 2%, revision rates 4%, and infection rates of 6%. The lateral takedown group had a statistically significant lower rate of complications, but what they determined was that the pathology of the individual should take precedent in the surgical approach. When you look at their results, one of the things that stood out to me is both the central and the medial approaches had a pretty significant percentage of patients, 6%, that had a hypertrophic or painful scar. And so again, sometimes the scarring itself, because of the location of the incision, causes complications post-surgically. So I think we can do better. This is one study that first came out utilizing the Astron, or started some of the Astron studies and thought process. It's a small cohort of patients, but there were 10 patients that were treated with ultrasound-guided approach. They resected both the bony prominence and also the retrocalcaneal bursa. And they looked at the comparison between a minimally invasive group and an open group. Again, small cohort, there were less complications in the minimally invasive group, but there were higher AOF AS scores in the minimally invasive group. And what they did see is there was a significant decrease in postoperative VAS scores at 2 weeks postoperatively with a minimally invasive group. So what they showed is that you can do a minimally invasive approach in a good way, utilizing ultrasound to both visualize the pathology and also visualize your resection of the bony prominence and the intertendinous calcifications. So that led us into some things on, well, okay, how do we approach our patients now? This is that classic patient, the 46-year-old male. He has pain with shoes and activity. He's on and off ladders all day long. Past medical history, he's a diabetic, but very well controlled. His last A1C was trending at 6.5, and he's been pretty steady with that. But he does have hypertension, OSA. He's a former smoker, uses smokeless tobacco on a daily basis. But the kicker was this: it was a 390-pound patient. And this was the reason it was referred to me. One of my partners, not Dr. Abik, I think Dr. Abik was on this call. Dr. Abik didn't send this over to me. He's not that mean. But this was a large patient that needed something done because he had difficulty with his daily activities and work. But at a 390-pound patient, this is one of those things where you say, can we do something differently? So there's the classic clinical picture we see of this patient. So what's our surgical approach? Well, my traditional approach for probably the last 7 years has been a central tendon splitting. I'm concerned about this patient. One, for his non-weight bearing status, I would require for that, the wound healing complications because of his body habitus, and the positioning. No one wants to go prone with a patient this large. It's a difficult procedure. It's a difficult airway. He already has OSA. We know it's going to be a hard tube for the anesthesiologist, and the last thing they want to do is flip them over. So I thought, well, maybe our lateral decubitus, that seemed like a reasonable approach. If I could get him in a lateral decubitus position, I would take a lateral incision on him to resect down the bony prominence and decrease the calcifications on the tendon. And then I thought, well, how do we do this in a minimally invasive fashion to also decrease our wound healing complications? So the interesting thing is when we got into the OR with these larger patients, when you put them to sleep and they lay, you know that their legs externally rotate significantly. And so at that point, to put him in a lateral decubitus position was basically going to have them almost in a prone position. So we sat him on the table like this, and I said, we can work with this. So this is how externally rotated this patient was, but we could get him directly on the C-arm for visualization to do this in a minimally invasive approach. And we draped him out, and we were able to approach him from a supine position, laying on the C-arm in this fashion, in the mini C. And when you're doing this, you're kind of like a driver. You've got foot pedals both for the burr to go, and you got a foot pedal for the C-arm, and you're going back and forth. Very, very different approach than what I'm used to with our open approaches, where it just seems pretty straightforward, but there's a lot of technical things that you look at initially. But as you get into this more and more, it becomes more and more comfortable. We marked out our landmarks on where we were going to make our incisions on C-arm. I initially started, this is one of the first patients that we did utilizing the Astron device. And I used to do it through a 4 incision approach. And this, you'll see what these 4 incisions are for. So the first incision I usually put just directly under the insertional enthesopathy so that we can resect that. I mark my plane out on fluoro to know where the angulation of my burr is going to be and the depth of the burr resection that I'm going to need to get this done. And then you insert the burr at that posterior incision and you make your resection. So I take off the enthesopathy first, followed by resection of the Haglund's deformity until we have a good debridement of both the calcification at the insertional enthesopathy and the Haglund's deformity itself. There's a lot of bone paste that comes out with this, and you want to be, pretty judicious in how often you're doing this to decrease the swelling around the area, but ensure you're getting all that resected bone paste out of there to prevent ectopic bone growth on the back end. And you flush that out significantly until it all comes out, and you can visualize it on fluoroscopy to see most of that bone paste and the calcifications removed. Then we go and we pass our sutures. So again, with this patient's body habitus, you can't really palpate the tendon posteriorly. It's going to be difficult to percutaneously insert these in the tendon without some sort of confirmation, and that's where ultrasound comes into play. So this is the telescoping needle where we're passing the sutures percutaneously and we're getting visualization with ultrasound. So you can see the tendon itself there, and you can see directly the path of the needle as it passes through the tendon to confirm that you have a good grasp on the central portion of the tendon. The other advantage to utilizing ultrasound is that you can ensure that you're not violating the sural nerve, avoiding a sural nerve complication, because you're doing this percutaneously. You're not staring at that nerve. But utilizing ultrasound, you can ensure you're in a safe passage away from that neurovascular structure to avoid postoperative complications. These are some other ultrasounds from the case itself. You can see the tendon there and the needle pass confirmed that we have good central portion bites on those tendons. And sometimes I will vary the angulation of the passes to pull it at different tensions along the tendon itself. So there's our final sutures that are being passed through. Now, when we first did this with 4 incisions, that most proximal incision was the incision that we would use to pull the sutures back through. The 10-min device is good for a couple of reasons. One, it's a blunt tip. And so when you push the tip either subcutaneously or throughout the peritoneum, it's blunt. So you're avoiding iatrogenic damage to surrounding structures, particularly the sural nerve. Once you are at the point where you have the telescoping needle in contact with the device, you open the trigger, you lock the device over the needle, and you close the trigger so that when you're pulling the suture back through the skin, you know that you're not pulling any other structures because it's only around the suture itself. So it's a very safe pass. It's a very simple pass to do subcutaneously. And once you get the workflow of it, it becomes a very, very quick procedure to both shuttle your sutures and then pull them out. So this is how we have them all pulled out through that most proximal incision. And then we go on and we make 2 distal incisions at the anchor point insertions. I use a banana lasso to retrieve the sutures initially, and we pull them out through the incisions on the medial and lateral side of the calcaneus for our anchor points. And then you can pull tension on that. And you can see how the skin kind of tense on that image on the left as I'm pulling down that tendon, confirming that I have a very good bite. My construct I'm using now is I have a proximal locking stitch and 1 additional stitch or suture pass below that. So I have 1 locker and 1 additional, and then we'll drill and insert the anchors to secure the fixation. Now, the other advantage to the approach that we're doing this with the minimally invasive burr is our resection is preventing us from having to do any sort of significant detachment to the native Achilles attachment. So when I'm setting my tension is already set for me because the majority of the tendon is still attached to the heel. And so really all I have to do is an in situ tension of what the Achilles is already at. So this is just a further, secured repair to ensure if we did have to debride off more of that insertion, we've got anchors that are locking the repair back into place. Once it's locked back into place, I push up on the foot to check the tension, and I squeeze the posterior muscle group to ensure that we're firing and everything's intact and we have a nice, sound, and secure repair. So post-surgically, there he is from the spur that we see before at the enthesopathy and the Haglund's deformity are now resected. And there's some small lucency you can see of the bone tunnels on the medial and lateral aspect of the calcaneus. And this is what he looks like at the end. So he's got 4 poke incisions. Again, this was our first constructs that we're using, and we've changed that a little bit, and I'll show you in the next case. So this is my recommended protocol because I didn't know how well this was going to hold up initially. This is very different than my double row repair that I was used to. So I still thought, well, I'm going to keep him in a splint for 3 weeks, non-weight bearing. He's also 390 pounds. I didn't want him to break through any sort of this rupture. And then we transitioned weight bearing at 3 weeks. We initiate physical therapy at 4 weeks. We return to shoes at 6 weeks and progress from there. This was this patient's actual post-op protocol. So he came in partial weight bearing at 1 week on the splint. He just couldn't stay off of it. The crutches were no good for him. He had trouble with the knee scooter. And so he admitted fully that he had been walking on it. But you can see his swelling post-surgically. It looks fantastic for someone that's been partially weight bearing, which means he's been weight bearing. So we took the stitches out. He was weight bearing in a boot at 2 weeks, and he returned to shoes at 6 weeks. And then we initiated physical therapy at that point. Here's the patient 8 weeks post-op. This is 75% weight on the operative limb as he's doing a double heel rise. And you can see 8 weeks post-op of a Haglund's resection in a 390-pound patient. I'm pretty happy with that outcome at this point. He had difficulty still with single heel rise, but the interesting thing is he had difficulty with the single heel rise on the non-operative limb. So that was just his baseline weakness. But he's pushing and flexing on this at 8 weeks without pain. He's been out of the boot, back in his regular shoes, and he was asking, can I go back to work? So we released him back to modified work duties at 8 weeks post-operatively. His VAS pre-op score was 8. Visual pain score at post-op 2, at post was 2. But at 12 weeks, he stated to me he'd already been climbing ladders. I advised him to not return to full duties at 16 weeks. Again, I was still worried about this repair in a patient this large. But he went right back to it full duty. 6 months post-operatively was the last time I saw him. He reported no pain. He had no significant strength deficits, and he was back to full duty without complications and was very happy with his outcomes. So we'll look at case 2. This is the last case we'll look at. This is a 46-year-old female. Chief complaint, the common thing we see, daily activities, pain with shoes, past medical history was unremarkable. But she was a very active patient. She's now training for half marathons and regular impact exercise. And again, this is kind of what we classically see in a female in the 3rd or 4th decade of life at a BMI of 30. This is a common pathology we see, difficult to treat. So these are patients that we can flip prone because I do think it's easier to approach it that way. And so this is what our surgical setup looks like now with these patients that we put prone. We swing the mini C over the operative table so we can do this under fluoroscopy with direct visualization and the minimal approach. Again, I start my burr just at the enthesopathy. We debride that down, and then we chase the Haglund's deformity posteriorly. And while you're resecting this, I will also push the posterior aspect, or I'll push the Achilles tendon against the burr if there are significant calcifications so that we can debride the calcifications at the Achilles insertion at the same time. The burr will also resect out the bursa as we're taking out the bone paste from resection as well. So we're catching the triad. We're doing the insertional tendinopathies. We're getting the retrocalcaneal bursa excised, and we're taking down the bony prominence. Through now, it's just 3 incisions, and you'll see what it looks like now. This is her ultrasound-guided needle confirming our proper placement of the needle within the tendon itself. And this is what it looks like now. So we have 3 incisions. We have 2 incisions on the medial and lateral aspect for our anchor points, and then we have that central incision where the burr is inserted to do all of our resection. Proximally, you can see the 3 little percutaneous holes that we use for the suture passing. Post-surgically, this is what our patients look like now. There are 3 incisions from an Achilles resection that chases the triad of the pathology. So what's the post-op course on this patient? Her sutures are removed at day 10, and she transitioned to partial weight bearing in a boot. I was pretty confident over our repairs on some of these patients that we could start them walking earlier. She was instructed to increase to full weight bearing with toleration at week 3. Post-op week 5, she came in with shoes. She said the boot was painful. I'll be honest with you, I haven't been wearing it. I've been in my shoes and I've also been walking on my treadmill, which is the last thing I want to hear in my patients is the non-compliance. But she was happy. She had no pain and she was ready to go. I didn't want her to go this early, but it seemed to work out okay for her. 3 months post-op, she returned to jogging and increased her exercise. So a significant ramp up of return to activity that I've seen in the past with my patients. If we look at some of the literature, particularly in the sporting population, it's a full 7.5 months return to sporting activity. Again, my patients aren't high-end athletes, but to have a patient 3 months post-op returning to jogging and feeling comfortable doing so is a win in my situation to get these patients moving faster. So what have our early results been? Well, I've had no complications to date with our patients. We've had no reported post-op nerve injury or lingering sural neuritis. We've had significant decrease in post-operative pain. And our return to weight-bearing activity is pushing boundaries, more so than I ever would consider or recommend to patients post-Haglund's resection. So we're seeing a quicker return and recovery to these patients, and the way we're approaching it by keeping most of the tendon intact, but also confirming well past sutures with ultrasound, we know we have a very secure and a very robust repair. So I'm going away from our incisions post-surgically looking something like this to going to something like this with improved outcomes. And it's really changed our practice and our approach to the patients that we're treating. Thank you. Any questions at all?
Yeah. Thank you so much for the.
I guess we'll turn it over to you, Maxim, right?
Yeah. Thank you so much for the wonderful talk. Yeah, we have quite a few questions lined up. So one question comes from a surgeon asking, what would, from your experience transitioning from the more open approaches, what was the most challenging aspect of that sort of learning curve to get to this point where you're showing us now?
Yeah, the most challenging aspect is, and I think anyone that is starting to get into MIS is understanding the burr. And what I've found is you can't rely too much on fluoroscopy. Your tendency is to try and use fluoroscopy as a guide, but as you get into it more, you realize it's more of a clinical feel, that you're resecting bone, but also looking down on the path of where your hand is. Because I think if you just sit there on fluoroscopy the whole time, it's really just going to both increase the length of the procedure, increase the need or the use of fluoroscopy during the procedure, but it throws you off because it depends on what plane the fluoroscopy is in. And so I think it's just getting used to the feel of the burr and how you're resecting these things. The other thing that, there's some providers I've talked to that maybe they're not familiar with ultrasound or haven't used it in the past. I will tell you the learning curve for that is you do the case once and you figured out, okay, this is simple. So utilizing ultrasound to confirm your needle placement, the learning curve is one case. It's very simple to understand your anatomy and understand where your needle's going with ultrasound.
How do you decide how much of the tendon to detach for this? Like, how do you go about that? Do you gauge off of the presentation of the burr and make a decision at the time, or is there a way to know preoperatively how much do you intend to take?
So a lot of it tends to be based on MRI. So most of these patients, I would say probably 95% of my patients, when I'm going to this point in their care, they have an MRI. So I understand what the disease state of the tendon is and how much needs to be debrided. But again, I think if you just remove the calcifications within the tendon and keep most of the native attachment intact, you're chasing the pathology that's going to get them to pain relief. And then utilizing the anchors proximally or the sutures proximally to anchor it back down to the heel, you have a robust repair, even if you feel like you've had to debride more of the tendon. But again, a lot of it is based on what does the MRI finding show me on the disease state of the tendon, how much I feel I need to debride.
Another question, how do you go about deciding whether to do this approach or an MIS Zadic osteotomy?
So that's a great question. I have not liked the Zadic osteotomy. I've done them open. I've done the minimally invasive, and it may come down. I mean, I've had some patients; they've done well with it. I think there's a lot more technical demand in a Zadic osteotomy, and it may just be that I'm just not great at Zadics, and so I think this has just been a better approach for me. I always worry about, with the Zadic osteotomy, we're leaving that enthesopathy in place. And the patients seem to be doing well. There's great literature that supports that we don't need to debride that because we're just disimpacting the pressure to the back of the heel. But I always wonder long term, is that going to be an issue? If we haven't taken that off, is that going to continue to cause traction pain? I don't know. I don't think we know the answer, but I feel better taking down that spurring. And so the patient can't feel that prominence still in the back of their heel.
Uh, when it comes to the ultrasound, for docs on the line that are maybe newer to it, what was helpful for you in adopting ultrasound for this approach? Like, was there anything you did, or how do you use it to identify the ideal location for your needle insertion? How did you find that process to be in terms of adopting ultrasound?
Yeah, so fortunately, I'd used ultrasound in the past on different things, so I was somewhat familiar with the use of ultrasound for different things. What I would say is, if there's any labs or even just get an ultrasound in your hand, I'll put a plug in for Astron at their booth at anyone that's going to ACFAS. They generally have an ultrasound there to let you see what it would look like as you go along the course of an Achilles tendon. But again, the learning curve for this indication using ultrasound is pretty low. It's a pretty simple procedure. And I think once you do it once, or even just play with it in a lab, or even take an ultrasound on yourself, if you've got one, a tech that you could see just to see what an Achilles looks like, it's a pretty small learning curve. And once you use it, you'll wonder why you never used it. Because you can confirm exactly where that needle is going. You can confirm that you're not near the sural nerve. And it just makes you think, I should have always been doing this.
From sort of a efficiency question, how do you find this approach with the ultrasound and this MIS? How does that compare sort of for workflow wise with the open approach?
Yeah. So the first couple of cases I did, I thought we could be done with the case by now if I had gone to my standard central splitting. So there definitely is a learning curve in terms of efficiency and OR surgical time. Again, they still haven't been long cases. We're talking an hour at the most. But now we've got it down to, the same time that our central splitting procedure was. They're about 30-minute procedures. But there does take some time to debride it properly, and until you're more familiar with the burr, there is going to be an initial setback in your surgical time. But once you get that down, utilizing ultrasound, passing the sutures, doing the burr, it becomes a very efficient procedure.
Got it.
To
Do you
jump in a little,
have,
sorry, Maxim. To jump in a little bit, there is a questions from if Maxim, you can read the
yeah, I'm
Q&A
about,
text.
yep, I'm seeing it. Yep. Do
Perfect. Thanks so much.
you have a cutoff for the severity of the Achilles tendonitis that would make you choose an open debridement instead?
Not yet. I mean, I think if you get an MRI and there's, just significant calcifications within the tendon, then yeah, it may make me think that I should maybe open this and debride it. But I think that would be at the point where I would have to consider an FHL transfer. If it's that significant, I'm probably going to consider an FHL transfer if we have that much disease portion of a tendon. But with the ultrasound, you can visualize some of those calcifications. Now, there was a comment that I thought these burrs weren't supposed to debride soft tissue. So, yeah, I mean, yes and no. I think what you're debriding is calcifications within the tendon. And if you push that burr, I'll use my thumb to push against the back of the Achilles tendon against the burr to remove some of those calcifications. Other calcifications, you put a pituitary rongeur in that hole, and you can debride the calcifications with a pituitary rongeur, which is another approach I've used for significant calcifications that you can visualize both with ultrasound and fluoroscopy. So there's a combination of both the burr and a pituitary rongeur, which I didn't show that in there, but that's another way that you can remove the diseased calcification portions of the tendon.
Have you used a competitive repair system? They're naming the PARS technique, and if so, can you speak to what advantages or comparisons or pearls do you find notable or significant between them?
Yeah, so I've used the PARS multiple times. I think the PARS is just it's a suture management issue. There's so many passes through the PARS. I never, you can feel like you're within the tendon itself with the PARS, but studies have shown that you're not always in the tendon with some of those passes on the PARS. I think the use of removing the PARS jig and instead utilizing ultrasound to pass the sutures with the telescoping needle is a much more accurate way to pass those sutures, and it's less cumbersome than the PARS jig.
Yeah, and I guess second question to that, in terms of the jig, it fixes the uh, proximal locations of where you can insert the needle versus with this approach, how important is it that you can modify based on the pathology of the tendon, where you're not in a fixed position, you can float it based on the patient's pathology.
Right, and I showed that in some of those ultrasounds where I will vary the trajectory of that needle. It's not always directly perpendicular to the tendon. I'll angle it down, but you're right. The morphology of the tendon is different, and the ultrasound will still confirm that you're within the central portion of the tendon wherever you put that suture.
Another question we have coming in, what is the largest Achilles tendon gap that you have found to be able to repair using the Astron system?
So you're talking acute ruptures?
Yeah, I think the question is about more Achilles, not Haglund's in this particular
Yeah.
case.
So if you are considering a large rupture gap, um, what we do is we augment those now with suture anchors. So if you have a large gap that you may not be able to completely reoppose end to end, well, with proximal suture passes, you're almost skipping the distal portion of the tendon because you're augmenting that by anchoring the proximal gap or the proximal rupture site back within the heel. What we've also seen is that, I used to do end-to-end even with the initial Astron. We would do the proximal and distal stumps percutaneously and tie them off. Now we're usually just securing the proximal portion of the rupture to the heel itself. And it plantar flexes enough that we think we get reapposition of the tendon edges, but they heal in. But you have the reinforcement of the anchor attachments to the heel that it's a secure repair. But I can't give you a specific number on the largest gap I've done. I mean, we've spanned some pretty large gaps where we felt like because we have augmented suture fixation, it's still a very sound and strong repair.
So to date, there hasn't been like a gap that was too large that you couldn't repair with
No,
Astron.
again, I think it also, it's the same answer on, how bad of a diseased tendon would you do this minimally invasive? If I have a large chronic gap or if I have a significantly diseased tendon, then I'm opening it up for an FHL transfer at that point. So it's a completely different approach and a different surgical mindset at that point.
Ben, this might be more for you. Question is, how can an ultrasound be used if the facility may not have one readily available?
Yeah, thank you so much. We have a portable ultrasound, and it's this very, very light unit. It's probably 500 gram, and then you can bring it. We can usually will support the physicians and bring it to the OR, and then Eileen is probably holding that right now. And so it's a portable ultrasound that link to an iPad. So we don't need a big machine to really do the procedures. Well, fairly we can use the ultrasound, portable ultrasound with the iPad that will provide it to the physicians.
And that will be available for those on the line that are attending ACFAS. I encourage everyone to come to the booth and play with it. You'll see how easy and nice it is to visualize using that. Another question, and this is maybe more in a generality, Dr. Carrington, whether it's for Achilles rupture or Haglund's, were there any challenges that you had on the first few cases, just overall with the system, or any sort of pearls that you adopted over time?
Yeah, I mean the challenges at first are just getting used to the telescoping needle, how you're passing it, and then and getting your feel for how the grasper actually attaches to the needle. And so there's some work throughs initially. That's where I'd recommend any sort of local lab that your rep could hold just to get your hands on the device and play with that technique a little better. A lot of times, what I'll do now is I will utilize a hemostat, curved hemostat, or a larger hemostat to almost just free up more of a subcutaneous layer, and it just makes the suture passing come through a little smoother. But again, the biggest advantage to the grasper is because it's blunt, that when you're passing it subcutaneously or within the peritoneum, you're not damaging any structures iatrogenically because it's a blunt pass to get up to where you need to. But there's an additional learning curve on just grasping that needle initially, but that comes really quickly. I mean, our last handful of cases, I think our most recent one was just last week. It's just a very quick grab and go.
Oh, this one is for Elin or Ben. Audience is asking, what is the booth number at ACFAS?
Booth is at 2332. Feel free to join. And I have an extra question for Dr. Carrington. So using the MIS Haglund deformity techniques, the windows is actually pretty small. How do you address the de degenerative changes in the Achilles? So you just do an open or you just switch to FL transfer that you just mentioned. Thank you.
The Clarify that again. The window is small to repair these. What do you mean? And
So do you address any to trim the tendons of the degenerative part, or you just leave the tendons as a whole in it?
during just a Haglund's repair that we're doing, or an FHL transfer?
For these MIS techniques.
So the MIS technique, I mean, we're debriding that tendon as much as we can, utilizing the burr and a pituitary rongeur. And I mean, we just debride until we feel both on fluoroscopy and with ultrasound that the calcifications are gone. Again, we're not staring directly at the tendon. So you're right. I mean, it's not like when we open it up and we can see all the mucoid degeneration, but we're treating the pathology, which is again, prominence of the bone, retrocalcaneal bursa, and the tendinopathy by debriding as much as we can, but we're securing a healthy portion of the tendon back to the bone so the repair is sound.
Thank you.
One question just came in. If there is not significant calcification within the tendon and you're primarily removing the exostosis, do you still need to suture the tendon?
No, that's a great question. You don't necessarily. If you feel like you're not disrupting the attachment at all, and you're just simply doing a bony prominence resection, which you should resect the bursa as well, then yeah, there probably isn't a need for reattachment. I just don't see a lot of those patients where it's just purely a bump. There's usually the triad of the bursitis, the tendinosis, and the prominence of the bone. But yeah, if it's purely just kind of a bump and run, yeah, there's no need to debride a tendon that's healthy and reattach it.
Okay. Any other questions to send in? Those that came late to the meeting, you will be emailed a recording to the webinar. I see that is a question that came in. So we'll be happy to share that. And and they just posted in the chat any additional links for anyone on the line that is interested to see the device live over a demo or see the technology or learn more. The company is on LinkedIn as well. Uh, I guess, Dr. Carrington, any other, oh, one second. Another question we have, can a combined equinus be addressed with this method?
Yeah, that's a great question. That's something we always test with the patient post-debridement, because a lot of times there's an equinus component to it. My equinus approach, or at least my releases posteriorly, is a small gastroc recession anyway. So if you're doing this, you can just do a mini open gastroc recession at the same time to address any sort of equinus needed. But I test those patients. I'm very hesitant to release posterior muscle groups if I don't have any sort of equinus component anymore. And so we test them post-resection to see if there's any residual equinus or tightness. And if there is, then we'll do a gastroc recession on those patients.
Anything else from the audience while we have Dr. Carrington on the line? Thank you so much for your time, Dr. Carrington. This has been very informative and educative, and it's exciting to see the possibilities of minimally invasive approaches. And it's although preliminary and low sample size, but we're very impressive results to see that kind of output from especially heavier set patients with other comorbidities. I know I'm excited to see the future of Haglund's after this call.
Thanks, everyone.
Yep. Thank you so much, everyone, for joining the webinar. And then thank you so much, Dr. Carrington, for sharing such a great results and insights about using Astron, integrating that into the Haglund. And then Dr. Carrington also does the procedure with acute with Astron. Love to see all of you at the booth during ACFAS if you're joined. Otherwise, you can book a demo, and then we'll be meeting you for a personal hands-on demo to see the ultrasound, the whole systems, and then on how to integrate it in your practice. Again, thank you so much, Dr. Carrington, for the great talk. The session ends here. Thank you so much all for joining. Have a great night. Thank you so much.
Thank you.